Hey, I think we are ready to go.
Yep.
Wonderful. So for those who don't know me, my name is Shauna Hashi. I'm here on behalf of the CSDH as a board member. So first, I would like to start by welcoming our in-person and online guests this evening and acknowledge that Dalhousie operates in the unceded territories of the Mi'kmaq peoples. Sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the peace and friendship treaties. Dalhousie also recognizes that African Nova Scotians are distinct people whose histories and legacies and contributions have enriched that part of Mi'kma'ki known as Nova Scotia for over 400 years. So for this evening, I will ask that for those that are joining online to mute their microphones and use the chat during the question and answer period. And for those of you who are in the room with us this evening, when it comes time to questions, please turn on your microphone using that fancy button that's in front of you, and that will allow those that are joining us online to hear your questions. I'll also note that this session is recorded and will be shared with CSDH members. So now I would like to invite Dalhousie CSDH Student Chapter President Annika Nobe to the microphone for opening remarks.
Hello, everyone. Thank you. Thank you all for being here, and thank you to those joining us online as well. As Shauna said, I'm the president of the Dalhousie CSDH chapter this year, and I just wanted to quickly highlight a couple of things the chapter has been doing. So earlier this fall, we helped screen at the Special Olympics Healthy Athlete Screening Day, where we screened over 60 athletes for oral health needs, as well as providing mouth guards to some athletes as well, which is super awesome. We'll also be attending in the summer as well for the Summer Games. And in the spring, we also look forward to always going to Prescott Group, which is a local community that provides individuals with IDD with programs, services, and jobs to learn important skills. So we go there and do some oral health outreach. And of course, we have a very exciting discussion lined up for you all tonight. And without further ado, we'll get the night going.
We'll get it started. So I'm going to introduce our first presenter, and then she's going to take it over to introduce her esteemed colleagues. So Dr. Tracy Doyle has been a member of the IWK Pediatric Dental Team since 2008. She holds a Bachelor of Science degree with an honors from St. FX University and a Doctor of Dental Surgery degree with distinction from Dalhousie University. After completing a pediatric general practice residency at Toronto Sick Kids, she obtained her master's degree and pediatric dental specialty at U of T. She is an undergraduate program director with the Division of Pediatric Dentistry at Dalhousie University and the staff pediatric dentist at the IWK. Dr. Doyle is a clinic director for Special Smiles within the Special Olympics, a CSDH member, and a proud mom of 2 twin boys and a beautiful little girl. I'm going to let her take it over from here.
Thank you, Shauna. So I have to say that my involvement with SO and then CSDH and it spiraled probably was somewhat by accident. I happened to be in my previous chief's office one day when the current, well, at the time, the director was there and trying to get Healthy Athletes started because we were about to host the 2018 National Games in Guinness, and we had at that point in time had no Healthy Athletes. And he's like, "Here, and this is Tracy." I was like, "What? What am I doing?" Okay. And it took me to Orlando where I trained, which was fantastic. I stayed at SeaWorld, and this facet of my career has blossomed into not only participating with CSDH as the mentor for the student chapter with Shauna, but helping to continue to recruit and Healthy Athletes here in Nova Scotia. I may or may not have also helped recruit Dr. Wright here today and Special Olympics. And I may or may not have been in a meeting at 4 to 5 and volunteered the CSDH chapter to help with the development of some pre-appointment videos or some modules of some sort, still in its infancy, to help pre-screening autism Nova Scotia. So they're looking at helping caregivers and the EIBI educators with things like medical and dental appointments. And we have as we're going to highlight, we have my visit to the dentist, but it's not specifically targeted towards those who are neurodivergent. So I think we could make spin-off, learning modules in that vein. So our objectives tonight are to help you as our next generation of oral health practitioners start the process of adapting your practice to help those who are neurodivergent, those who are living with intellectual and developmental disabilities, prepare themselves for the dental environment. We know, we're just taking autism spectrum as one specific group of individuals who sort of have trouble with the dental experience, because as we know, there's three main deficits: stereotypical repetitive behaviors. Our patients with autism love routine. So going to the dentist is out of the routine. We see that a lot with our patients at the IWK. They just come and they're just off right from the beginning because it's not my regular routine. If I can get on the bus and go to school and meet my EA and have my day at school and those things that I'm used to, my parents woke me up instead and put me in the car and took me to the IWK, and I really don't want to be here. That's common for us to see. And then of course a lot of our patients with autism have a lot of oral sensitivities and environmental sensitivities. Walk into these noisy dental offices and you hear the drill, and you hear other crying children. The smells are different just coming into a hospital. Then you go into the dental office and that smell of, we all love you, smell of eugenol, we all associate with the dental office. Those things can be very, very exciting and very difficult for a lot of our kids to adapt to. And then of course, there's also some problems with communication. So some patients are not verbal or have limited verbal capacities, and some are very verbose. But being able to communicate what they're scared of sometimes is a little bit tough. But we have some very good examples of kids who are very verbose and very fixated on certain aspects of their life. We have good fun at the IWK. We have lots of kids who come in. I have one little person who comes in and asks everybody if they have a cat or a dog and what is their name. I even had one child once upon a time who, just like you can be really interested in cars or hockey players, he was really interested in toilets. And his thing was, you could go into the bathroom and say, that's a American standard, so much liter flush with this many liters. And I was just like, we all have our things, right? So we want to talk to you about a lot of preparation that can happen that's outside the dental realm, like outside of your office, things that you can help caregivers with to help then prepare their little person or their big person for that dental experience. With social stories, I'm going to talk about. Joanne's going to focus a lot on desensitization in their realm and what they do to help us help their patients cope with the dental experience. I'll talk a little bit about the research we've done about adaptive oral health aids, and then we have the esteemed Dr. Wright, who has really changed the experience for our patients at the IWK around that perioperative surgical experience.
The chat is just asking if you could stay more.
This mic? Okay. Okay, I'll try. I like to walk around though, and I have to put it down a little bit too. Okay. So we know that this population has barriers to care. We're not going to, fixate on this, but we know that our patients have a lot of fear and anxiety. A lot of our kids who come who are neurodivergent also have comorbid conditions, so they can be over medicalized. They've had a lot of experiences with, and sometimes negative experiences in the hospital environment that then translates to the dental environment. We see with some of our athletes that they feel like they don't really need to have dental care. At the last games, I was asking a patient, or an athlete, when did you last see the dentist? Oh, 10 years ago. And why don't you go? He's like, it's just not something I do. It was his response. And I said, do you think if I lined you up with a professional, you would go? And he was like, no, probably not. So it's very honest with us, but just don't believe that if nothing hurts. They don't believe they have to be there. And that could stem from also the dental IQ of those around them and the caregivers that they have. Some have a hard time tolerating dental treatment for those reasons we just discussed, and inability to communicate is also different. Costs are there. Now we have some barriers that are broken down with our CDCP, or our Federal Canadian Dental Care Program, and thanks to Olaf and the rest of the board for advocating to federal government to advocate for certain certain procedures in the guide that was covered, like extra units for desensitization and getting certain persons used to the dental environment.
treatment and being able to bill for that. We talked about changes in routine. Some of our athletes too are not responsible, for their own transportation a lot of the times, may live in group home settings and have to rely on others for transportation. There's also in some of our rural communities, there's a lack of dentists, which we never think of it as an issue here in the city. But, my South Shore athletes, for instance, when I try to look for a dentist for someone from Shelburne or Yarmouth, people are on wait lists down there just to have a family dentist. So that's a little bit tricky as well. When we look at the need for care, this is the data from the 2018 games showing us that we screened almost 350 athletes, and our percentages were similar for the big ones, like having untreated tooth decay, having diseases of the gums or periodontitis or gingivitis, as well as those patients in urgent need or have oral pain were similar. Somewhere between 10 to 15% of our athletes were experiencing pain, and 20% up to 40% internationally have untreated tooth decay. And when we think about the screening process, that when we screen, for those out there, we're not using an Explorer. So we're not talking about little tiny Pitt and Fisher caries that you can detect from a sticky Explorer. This is visual open lesions. So you can know that these numbers are probably conservative compared to what the real rates of disease are, because we're also doing it without radiographs as well. So what can we do to individualize the dental experience for these patients without significant burden both to the healthcare system and to your individual practices, right? One, I'm going to show you an example. We won't go through it question by question, but of our pre-appointment questionnaire. The other really important part are our pre-appointment visits to your office can be very helpful. We'll talk about that in detail, but tell, show, do. Just starting really, really simply. And I do this with every kid I see. Doesn't matter, their neurodivergent status, whether they're typically developing or not. The first thing I do when a child sits in my chair, I do not go at them with a Pokey Explorer and try to poke that into their mouth, right? I always take their fingernail and I always gently brush it. And I do that for all my kids. And if they're a little bit shy to do that, then I'll demonstrate on a caregiver or Stuffy, or sometimes if you've ever met my friend Twinkles, sometimes when Twinkles is with me, I'll do that too. Positive reinforcement is really great. Most offices have toys or stickers or whatnot, and those are good motivators. We have to watch though in the real life setting in terms of positive reinforcement. A lot of caregivers do substitute food items for positive reinforcement for patients. I once had a little girl, and they were trying to increase her vocabulary, but every time she said anything, potty, I need to potty, I want a glass of milk, she got a Skittle. Every single time she said anything, she got a Skittle. So you can imagine that was a little hard for the family because they were making progress with her vocabulary, but it wasn't doing anything good in terms of her oral health. We want to modify the environment to minimize sensory input. So one of the big things in our offices at the IWK, they're all closed, like enclosed spaces with doors. That's a little tricky in the dental school environments, that they're all very open concept, but we are working towards some smaller spaces or enclosed spaces, even at Dalhousie, as we work towards a multidisciplinary clinic for those who are neurodivergent. But that's really important in an office to have at least one space you can have that's quiet away from the rest, to minimize the noise that's happening in the rest of your office as well. We'll talk about social stories in one sec, but one of the biggest factors that is repeated in the literature when we talk about children who are adherent to routines. So more specific, our patients with autism, trying to minimize waiting. So that's a huge one. And Stuart and I deal with that on a regular basis, because for the OR, for instance, our patients are made to arrive an hour and 45 minutes before their operating room time. That was increased during the times of COVID because they used to swab, but never really shrunk it back down again. It only keeps getting longer and longer. And that's really, really hard for some of our patients to wait. And sometimes that is the triggering, stimulus that turns a patient who may be able to work with, but they work themselves up with all that wait time and all that people coming in and out, that it can be very, very triggering for some of our patients. So we try to, those who have trouble waiting in a busy waiting room, we try to do that first of the day or first after lunch to minimize that wait time that we have. So when we talk about social stories, these can be generic or commercially available. There are tons. So when we got some funding at Dal to purchase children's books related to dentistry, I got to research what's out there. Almost every single like commercially available cartoon character has a story. Dora, Bernstein Bears, like old and new. So there's tons available out there about the dental experience. Some are better than others. The Bernstein Bears is really known for the one where they have the big bear trying to give the needle. It's that's not one I would recommend. But some of them you have to flip through them. But there's many available, or you can individualize for your office. So we'll show you what we did at the IWK. But basically, a social story is a series usually of photos, or we did make a video one as well, where you are breaking down the dental visit into individual parts that are associated with some sort of visual input as well, written in developmentally appropriate language, so usually to appeal to a child that is simple. And by explaining the context in which a dental appointment is going to happen, you can replace information that the individual may not be able to glean for themselves. So some of the instances are like, that they're supposed to sit in the chair, and maybe the assistant's going to put a bib around the neck, and maybe they're going to shine the light. So like preparing them for all of the different steps so that they have some pre-preparation. So they're powerful tools to help a patient specifically or non-specifically with ASD prepare for these new social situations that they can't take information from related experiences and sort of incorporate that into the visit. So by explaining the context, providing that information, they can then model their behavior and use it as a rule to behave properly in the setting. So we developed one at Dalhousie with the CDH chapter a few years ago. It's a 9 to 10 minute video broken up into different pieces. One is just related to coming to the dentist, coming for a routine checkup, coming for a restorative visit, and we do show them a nitrous oxide hood, and then as well as a home care bit at the end. And we did that on purpose, put it into segments, because there's some fatigue for some of these kids to watch a full 10-minute video. So that's available on YouTube. You really only have to search My Trip to the Dentist. We have a QR code. Anybody can contact me, and I'm happy to provide you with a poster to hang in your office. We made one of my students quite a long time ago made a copy of the social story using our clinic. And just to give you a few examples, so this is what the entrance to our clinic looks like, right? And the language can be very simple, layperson terms like, I'm going to the dentist today and they're going to check my teeth. This is what the reception looks like, and so on and so forth. So, there's a lot of dialogue that you can get like examples of social stories in the literature to show you to use the language. You can make it up yourself, but it's best that you use pictures of your own office to individualize that for what the patient's going to see. So just showing you all the language here. The second sort of pre-preparation that you can do that really you're not involved with. This is all stuff that parents could do at home, right? So these social stories would be things, sorry, moved up my mic. These are social stories are things that parents are going to do with their kids at home. Really has nothing to do with you besides providing this information. So it's not taking your chair time, right? The parents will repetitively read these stories with their children, and some may need it once, some may need it twice, some may read it 50 times, right? So everybody learns at their own pace. The second thing that you can do is use a form of a pre-dental questionnaire so that you can get to know your patient even before they come, so that you could avoid some of the triggers that a caregiver may be able to warn you about from the beginning. This is one called the Determined program, but there are many out there. I believe one of our esteemed colleagues from CSDH, Clive Freeman, had a hand in developing the Determined program that I used. And he actually was one of the first people that introduced me to the concept of desensitization visits. So he had a beautiful office that I went to see in London back when I was in grad school, and he had a play area downstairs. And so what he would do is when a patient came, he used to, instead of doing it multiple times to save time for that family, he would do it all in one day. But they would go up, they'd see the office, then they go downstairs and play. And I think his wife is also a clinical psychologist, right, as well. So, and then he'd take them back up, and maybe they'd sit in the chair, and then they go down and play. But you could do this over time. And I have a wonderful little patient that came to me after seeing me on TV, with Twinkles when we were talking about the adaptive aids reached out and now comes to see me on a regular basis. And I was able to take a child who would barely walk in our clinic to now will let me use an Explorer and take a panoramic radiograph over a series of 5 or 6 visits. So it really works. Just in a busy healthcare system, like at the IWK, we don't have a lot of time for some of this regular desensitization visits. But this is certainly something that can be adapted to any dental office. So just a pre-questionnaire asking about health history, asking about social history, asking about supports at school, where they are in their grade and with their peers, and the big thing about we just talked about in terms of what they're doing for positive reinforcement, using something like behavior bucks that they can cash in for screen time, sometimes versus sugary type treats as rewards. And the biggest things is, what do they like? Are bright lights a trigger? Are smells a trigger? Are textures a trigger? If a kid really doesn't like the tags on their shirts, probably they may not like you putting the bib on. That might be a bit of a trigger, right? Some kids really like the feel of weighted blankets. So they're really going to like it when you put that lead apron on for radiographs. And sometimes we've used lead aprons, not as lead aprons for radiographs, but as a surrogate for a weighted blanket. And I like the last part of my questionnaire. When going the wrong way, that when I gave it, I always say that expectations have to be managed. So you also have to know the expectations of your patient and your family, because your expectation might be that I'm going to take this patient in, I'm going to do a prophy, I'm going to do a checkup, I'm going to take 2 bite wings and put fluoride on, and the patient's go. And when I asked this mother what was her expectation of success, she was like, no one gets bit and everybody's happy. It's like, that's what she wanted. She didn't want her child to hurt anybody else. So also asking what the expectations for that particular visit is also something that's really, really important. And just not feeling like a failure if that you don't get all of the standard things done. Maybe just the first time that a child sits in a reclined dental chair can be a big deal, because as Rebecca and Allison can attest, we do exams in regular chairs. We do exams in the waiting room. We've done exams in cars. We do exams on floors, anywhere that child is comfortable. And so talked a little bit about this and our questionnaires. I just wanted to get to this video, and then I'll show you my adaptive aids before we go, or I turn it over to my colleagues. Now, hopefully my video plays. Communication could be a big factor, knowing your child's developmental age. We don't speak to grown-ups and our athletes. We don't speak to them like 5-year-olds. And we often have to use appropriate language when we're speaking to 5-year-olds.
It's both unjust and tragic that people with intellectual and developmental differences all over the world receive substandard health care. In community after community and country after country, we have seen the toll of healthcare injustice. This video is our effort to amplify the voices of people with intellectual and developmental differences, amplify the voices that ask for fairness, for care, for equality, for justice, from their healthcare practitioners and all those who support them. We hope that in doing this, that the needs of people with intellectual and developmental differences will be seen not as burdens, but as gifts to be recognized and treated and cared for by every healthcare practitioner in the world.
Athletes with disabilities are just like everyone else. They just want to be seen, feeling respected.
Get to know me.
Get to know me.
Try to get to know them first and try to see what their health issue is. You can understand their health issue at first, then you get to have a first-hand perspective of how they're feeling physically.
Treat me like the other patient. Look at me.
Look at me.
Talk to them person to person. Treat them like an adult, not like a young person, like a young kid. Talk to me and not my mom.
I can speak for myself.
I can make choices about my health. Don't be afraid to work with people like us. We're more in life than we are different. They're just like any other patient. They have health troubles.
bones, discomfort problems. It just may take a little bit longer to listen to what they have to say.
If our athletes aren't healthy, they can't perform well. They can't go to practices. They can't compete well. They're not well. So Healthy Athletes has become a very important program, I think, to so many of the athletes, and gives them another way to connect with professionals that are outside their realm.
You can look into Special Olympic stories and you'll find ones where dentists have found mouth cancer in kids that have never been to a dentist. Like, it's a great way to go out and be a provider and maybe catch something that's never been caught before on some of these individuals.
It's important to be healthy so that I can do the sport that I love.
It's important to be healthy because you feel good about yourself.
The same reason for everyone else to be healthy, so that you can be the best version that you can be.
I want to be as healthy as I can be.
When you're asked to treat someone with a disability,
You say yes.
You say yes. You say yes.
You say yes.
Say yes, and mean it.
I love that video. So the last little bit is we did a student-led project a couple years ago with Megan Tobin, who's now practicing in Sackville. And we asked members of the CSDH, as well as the CAPD, which is the Canadian Academy of Pediatric Dentistry, what do you get asked by caregivers about oral health? Like what do caregivers ask you about? Do they ask you about what to use, how to use it? And so we got some very, very good information. So we got some evidence that a lot of our experts in the field are recommending a 3-sided toothbrush. And because of that, we got funding and we now have what's called the surround. We call it a 360 toothbrush, now available for all patients at the IWK at all times because of this research. They also recommended things like mouth rests or mouth props to help caregivers so that they can access the oral cavity, and recommending techniques like our standard knee-to-knee examination that doesn't have to be just for our young babies, as well as always coming from behind, supporting the head in order to access the oral cavity. In a nutshell, we found that almost on a regular daily basis, caregivers are asking their oral health practitioners about adaptive aids and techniques to brush the teeth of those that are kind of unwilling at most of the time. And not so different than our pre-cooperative children as well. But they did find that a lot of caregivers, they did not feel that they were confident that those caregivers were going to be able to carry out the information or purchase some of the products that are recommended. So again, at the IWK, we're very lucky that we got some money through the Thistledown Foundation to support the buying of flavorless fluoridated toothpaste, for instance, for those who have taste sensitivities. We got these cool things called gum chucks. So for those kids who have motor or dexterity problems, big gripping handles so that they can have more independence in their oral health care. Things like the turtle brush. That wasn't one of my favorites. I got a few and used them on my own kid. Really kind of like hard to grip, whatnot, maybe for the really, really young, but revolutionary is the 3-sided toothbrush that, funny enough, on Amazon, if you look, sometimes I call it the autism toothbrush, which I thought kind of, it was kind of interesting, but really it's just bristles on all 3 sides. I say more bang for your buck when you have limited time. And then for in your office, some of the more specialized things that you use are, there's flavorless fluoride varnishes for those who have taste sensitivities. We have different forms of mouth blocks and mouth props that will help you to keep a patient open. And then of course, protective stabilization. So for those who have involuntary movements or really like that feeling of that feeling of being cocooned in our burrito, protective stabilization can be very good to put someone at ease, make someone comfortable. So in conclusion, really, we just, as practitioners, the vast majority of our patients who are neurodivergent can be treated with very little adaptation in the dental office, maybe just a little bit more time and patience is necessary. For those of you, I always put a plug in for Special Olympics. We have a team going down for July 4th for both healthy athletes of all disciplines. We have Stuart here, who's our clinical director for MedFest. We have Joanna's training to be a clinical director for Strong Minds. So there's lots of opportunity to volunteer, because the Special Olympics thinks that when athletes compete with those that are similarly abled in competition, that it builds families, it builds communities, it gives them confidence and the ability to then live their lives as confident individuals. So let me win, but if I cannot win, let me be brave in the attempt. So same as you all out there when dealing with our athletes, right? So come and please come be our partners. So that's it for me. Thank you. fast. But I would like to introduce Dr. Joanne Gillespie. So I've worked with Joanne for a long time now at the IWK. She's a psychologist and joining us from IWK Health. At the IWK, Joanne works in the Pediatric Health Psychology Service, where she supports children and youth with chronic health conditions. She also coordinates the predoctoral residency program for the IWK Psychology. Joanne is an assistant professor and clinical associate at Dalhousie University in the Department of Psychology and Neuroscience, and does a small bit of private practice at the Dr. Hubley Carruthers and Associates in Halifax. And I know that our health psychologists are in a wonderful position to help us with particular kids who, for instance, have needle phobias and things. They come and use our clinic space at times for their desensitization programs and our assets and allies in care. Thank you, Joanne.
Hello. I'm not sure. I'm not used to using a microphone because I'm usually this person as well, but I'll try my best to stay here. In terms of promotional material that went out, I don't know if my name was actually on it. So Elizabeth McLaughlin is my colleague in the Pediatric Health Psychology Service, and she was going to be here tonight and then had to step away for personal reasons. So I am stepping in happily in her place in order to be able to be with you tonight. So I'm a pediatric psychologist speaking from the perspective of someone who works with children and adolescents, and a fair bit of what we do within our service is folks who are neurodivergent, folks who have intellectual and developmental differences, so broad range of different kinds of things. So I'm going to approach some of the behaviors that are challenging as anxiety. So I'm going to give a little bit of information about dental anxiety. Then we're going to talk about some behavioral considerations in the dental clinic. And then an overview, if you end up involving a pediatric psychologist, what that would look like. So you have a sense of once a referral goes off to psychology, what we actually do. So the most common behavioral challenge in pediatric dentistry is dental anxiety. So anxiety, as you know, is an evolutionary response that we all have that helps keep us safe. And dental anxiety is a very specific kind of that. So if we look at different prevalent studies, it's seen across the world and across age groups. It's especially common in young kids. So 2 to 6 year olds, there's 30% that are reported to have significant anxiety. Within autism spectrum disorders, 68% of folks reporting or parents reporting significant dental anxiety. And then within the IDD literature, 20% of those with a moderate kind of challenge are reporting severe dental anxiety. Dental anxiety doesn't go away generally without treatment. And so kids that have this challenge tend to become adults who also have the problem. So it's really important that we're thinking about this early on. When anxiety becomes very, very significant and interferes with the ability to go to the dentist, to seek oral care, to do things, then it becomes a phobia, and there's different diagnostic criteria for that. But if you look at the literature, it's odontophobia or dentophobia is how people tend to call that, and it might be for a variety of different kinds of reasons. So the idea of anxiety leading to avoidance is important within dentistry, because if someone has a hard time going to the dentist because of anxiety or fear, they avoid it. Typically what happens if there's problems, they get worse. And then when they go to seek treatment, it is going to be even more difficult, which then reinforces the whole cycle. And Tracy, when you were referring to the kiddo that said, even if a professional or the young adult, the professional was here to seek treatment, no, I don't need it. I was sitting and wondering, is that because there's anxiety there? And the avoidance is, of course, I don't want to do anything. If I don't have pain, I'm fine. And I can just avoid that uncomfortable situation. So in terms of what we want to do, these are true certainly for folks who have ASD, IDD, generally people who have anxiety. So young kiddos, adults, all across the board, good kind of strategies to think about. So importantly, when folks come into the clinic, really giving them some time to kind of settle in. We know anxiety is a curve that goes up and goes down. And if we can give people time to feel comfortable and kind of figure out their environment, it's going to pay large dividends. If you think of folks who paint, they talk about the most important part of painting is the preparation before you paint. And so this is a way to really think about we're laying that stage so a more successful visit can happen. We want to use really clear instructions and commands. So there's a difference between an instruction and a command and a request. And so we want to be using simple language. We want to say things that are developmentally appropriate in short kind of phrases. And we want to think about how can we use do language. So do is something like, please come sit in the chair versus don't go over there. Or don't run is different than please walk. So we're trying to give people the option of what they can do and what we want them to do instead of the things we don't want them to do. The command piece is really important. So if there's a choice to be made, wonderful. If you can give a choice to someone in terms of you can sit here or you can sit there, I don't care where I'm going to do the exam, that's great. But if there's not an option of a choice, we don't want to phrase it as a choice. Do you want to? Do you think you're ready to? Could you do this? Because really you're inviting the opportunity for someone to say no. And if you're going to make them do it anyway, then that's not great. So if it's something that does involve a choice, give it. And otherwise we want to use a kind, friendly command. Please come sit here. It's time to do that. We also want to think about information that is both procedural, so step by step by step, this is what I'm going to be doing, but also sensory. So what can someone expect to hear, to smell, to feel, for how long, so that we're able to give them all that information and they're more likely to have a positive kind of experience because of that. The choices piece I just mentioned, so thinking about beforehand, is this actually a choice or not? And if it's not, don't make it one. If there are opportunities for signaling needs, that can help people feel more uncomfortable. So often anxiety is because of uncertainty. And so if you don't know what to expect and you have the feeling that I'm helpless and things are being forced upon me, that can be very overwhelming. So if there's an opportunity to do signaling in some way, so that if someone has their mouth full of things and they can still give you a sign that they need support, that can cause someone to feel much more comfortable, which is good. There's also a fair bit of literature on sensory adapted dental environments, which I'm sure people are aware of, but looking at the lights and the smells and the noises, if there's different opportunities for different kind of things people can hold in terms of sensory kind of toys and gadgets. If you look at the literature, certainly there's nothing that says they're not helpful. Different folks find different things in terms of how helpful they are and what particular pieces of the visit they help. So we know that physiologically, in terms of what's happening in that anxiety response, the SAID can actually help decrease the physiology. Some folks say behavior improves, which is great, and other folks say behavior doesn't really change a whole lot. So it's not clear to me as I look at that literature exactly what's going on in terms of the change, but thinking about, can we have quieter voices? Can we dim the lights in some way? Can we close the door so it is a quieter environment? Is there a way to make things not so loud and overwhelming? And the hallway going to dentistry at the IWK is fluorescent green. And every time I see it, I think, who picked that paint color? Because it is so bright and overwhelming. So just really thinking of what the environment looks like. Distraction is super helpful in anxiety, which I'm sure you've all found yourself when you're in situations where you feel anxious. Distraction is great. And music is one of the things that consistently across the literature really shows to help calm in an environment. That's for children, for youth, and for adults. So thinking about kind of what's playing can be helpful and what that sounds like. Reinforcement is super important, as Tracy was mentioning, and so it can be tangible things, but it can also be social reinforcement. So the use of high fives, of smiles, of praise, of attention. So it doesn't have to be necessarily giving something to somebody, but thinking about, am I seeing a behavior that I want to see more of? And if that's the case, we want to reinforce it. And so that can be with a smile or a high five or saying something. Or if it's something I don't want to see and I want to remove attention from it, then that's a way to decrease the chance that that particular behavior is going to continue. And so it's really thinking about, is this something I want to see more of? Attend to it. Is this something that I want to decrease? Take my attention away from it. Unless it's a safety situation, of course, then those kinds of things you don't want to remove and take your attention away from. If you're using praise, you want to be very genuine. People are excellent, especially when they're anxious, of picking up when you are not saying something that they believe. So be genuine in your praise. We want to do it as soon as possible. You see a behavior that you want, praise it. Don't wait till the end, because praise loves momentum. And if you're able to build on it, then that's going to be a really good thing. We want it to be very specific. So instead of great job, if you can say something like, you're doing an amazing job sitting in the chair. Instead of at the end of the visit saying, good job, giving a high five, saying something like, you did a really nice job listening when I asked you to do this, or you did a really great job coming into the clinic room, whatever the case might be. We want to be specific. Reassurance is something that we all do. And what the literature shows us is excessive reassurance by adults actually increases distress during procedures. So if you are a person who tends to say things like, everything's okay, it's going to be fine, don't worry, what we know is that can actually make things worse. If someone is already feeling anxious, in the short term, it may decrease their anxiety, but it's also signaling them that there's something I should be worried about, because why is the grown-up telling me not to worry if I don't actually need to worry? So just being mindful of kind of what you're saying and how you're saying it can be really important. We also want to think about ending the visit with a positive. So it's not pretending that a visit went amazing if it didn't actually go amazing, but you can always find something during an interaction with a family that you can actually reinforce. Because what we know is that gets coded. And so the next time there's a similar kind of situation, that part could potentially be remembered in a very positive way. So you did a great job with this particular piece is something that can be encoded for the child. It's also really great modeling for the family because these visits are super stressful often. And so if they're able to see you're not upset, you're working with the family, there were some good things that came out of this, that can be super helpful as well. Then desensitization is the big piece. And so what we're looking at here is really trying to shape behavior. So shaping is gradual approximations to a desired behavior. So you're thinking about where do I ultimately want to get and what are the very many steps along the way to get there. And then the desensitization part has to do with changing the anxiety that's experienced to something that's more calming and relaxing. So exposure generally is desensitization and shaping, and it's really thinking about how do I get them where I want to get them with the expectation it may take a very long time. So again, that idea of preparing before you paint, this is the example of that as well. Small gradual steps to get to a really positive outcome over time. Tell, show, do, modeling, and social stories are all examples of desensitization. Books about going to the dentist are great. Social stories, excellent. I really like when it's a picture of the kid themselves doing things in the environment where they're going to be. So again, you can kind of really very much personalize these because to me, that's exposure. If you have the child in a situation and they're doing the thing to get the photo, and lots of kids like to get their photos taken, then you've actually exposed them to something. You can praise them for that. You have evidence that they did it. And then later when they're looking at it, they can see themselves doing it. So modeling we know is really helpful for success. And if you see yourself doing something, then you're actually modeling your own behavior. CSDH, which hopefully everyone knows, has a really great sample kit in terms of desensitization and the steps and what families can have at home in terms of how they can prepare so visits go better in the future for their kids. If you decide, I don't know how I am for time, keep going or I'm okay? A few minutes, okay, perfect. If you decide I don't have the ability to do this because desensitization is going to take a lot of time. So parents report it's super helpful to go to a dental clinic and do the practice gradually over time. But it takes a lot of time, which means time from work, time from other kinds of activities, and it can be expensive. Again, time from work, parking in the days when we used to have to pay for parking at the hospital, and just kind of figuring out childcare for other kids. So it does have cost to it, even though it does have significant benefits as well. So if you decide you want to refer to a psychologist, what we know is evidence-based treatment for anxiety is cognitive behavioral therapy, which is CBT. For many of the kiddos we're talking about in terms of neurodivergent or folks with IDD, it's probably going to be more of the BT. So we're doing behavioral intervention and less of the cognitive piece. Same principles, but just kind of different in terms of exactly what it's how it's delivered. So a big piece for us is psychoeducation, giving information so that families know this is something that's happening because of a biological response and things are very stressful. And it's not that someone is trying to be difficult or they're not cooperating on purpose. It really is physiologically something that's really difficult for them to manage. We do a lot of teaching of skills to try and reduce that physiological response. So talking about relaxation, breathing, helping people to feel kind of like their body is not betraying them and they don't have to get it out of that situation. If it's someone who's able to kind of recognize the unhelpful thoughts, like the needle's going to break, the dentist's going to hurt me, something bad is going to happen, then we can work with them to kind of figure out what's the evidence for that and against it, and how can we come up with an alternate thought. More likely in the kind of population that we're talking about tonight is going to be coping statements. So having someone practice saying, I can handle this. I am brave. I can do it. There was a meme somewhere that said, your mind is always listening, so make sure it hears something helpful. And that really kind of exemplifies this. So if we're going to be saying something, we want to be practicing the things that are going to be helpful. And so we can get kids to do that over and over again. In bold, repeated exposure is really, really important, and gradual is an important word there. So we're doing the thing where we're breaking down the steps, bringing people into the situation, praising their successes along the way, and we're doing it in a gradual way, because the opposite of that is flooding. And so when you're doing tell, show, do, just be aware of that piece, because if you give all the information, sometimes that can be really overwhelming, and it does the opposite of decreasing anxiety. It really kind of put someone into total fight or flight. So gradually is what we would do, and really being very systematic in terms of what that exposure looks like. Distraction, as we mentioned before, is super helpful in terms of managing anxiety. Interestingly, when we're doing exposure, we don't actually try and distract the kid because we want them to experience some of that anxiety, feel like they have some control over it, and then a sense of self-efficacy that they can manage it. So we don't put exposure and distraction together. When we're actually doing the procedure for real, then do all the distraction that you want to do for sure. And then back to the reinforcement part, working with families to figure out what motivates this child, how can we use that to our advantage in terms of having reinforcers that are going to be motivating for them. And again, breaking things down small and then giving rewards along the way is really important. Visual aids is the other important piece in terms of thinking about social stories would be a visual aid. Sometimes you can have a board of kind of these are the activities of what the day is going to look like. It can be a whiteboard. It can be Velcro strips that move back and forth. But if anxiety is the challenge, really thinking about how do we give some certainty? How do we give information so the person feels like they have a bit more control, and knowing the schedule of events and knowing what to expect can be very, very helpful. So in terms of unique kinds of things that hopefully you can take home for the neurodiversity piece, having a really good sense of what the experience has been like in the past, as Tracy was saying, is important. So having that pre-screening questionnaire so you know kind of what this person has been through and what some of the challenges might be. Getting information from the individual or the caregiver that's coming to the appointment. What have appointments been like in the past? What's been helpful? What's not been helpful? So you can really get a sense of how do you use some of that information to guide the appointment that you have. Thinking about your communication, again, we're using very kind of simpler language. We're giving commands versus asking questions and seeing if people want to do things. And we're trying to be direct. So one of the challenges with ASD is communication. And so if we're using things that are kind of harder to get your head around, if there's jokes and euphemisms, that's going to be harder. So we just really want to think about a language that's very direct and straightforward so that people are able to understand what we're telling them is going to be happening. Modifying the environment. So again, thinking about the lights and the noise. Aromatherapy is some of the, in the literature, there's pieces about aromatherapy. I don't know how easily that works for folks who have sensitivities, but it's there. And then that idea of weighted vests, or if someone comes in and they have a particular sensory object that they like to have, being able to hold that while they're in the clinic can be helpful. And then just a last plug in terms of interpretation of behavior. So again, thinking about non-compliance, lack of cooperation, fight or flight, really is often about anxiety. And so if you are in a situation where you have sensory differences and there's a whole bunch of things going on that you're not used to and you don't really understand, then the connection between how your brain works and how you interpret that can come off as, I want to get myself out of this situation. And so it's not a kiddo who's trying to be problematic or uncooperative, they're scared. And so they're really trying to get themselves into a safer place. So just kind of reframing it like that, I think can be helpful because we know it's stressful for families to come to these appointments, and it's stressful for healthcare providers when they don't have appointments that go really well. And so thinking about it like that can be helpful. There are some ASD specific resources. The websites here that I've listed are ones that have lots of great information. So the Canadian Dental Association has done an amazing job of organizing things in terms of for families and then for professionals, and there's lots of different information. Autism Speaks has social stories, scripts that can be used. And then the Nova Scotia Dental Association has a really nice toolkit as well, among others, but these are easy ones for people to access. All right, so wrap up, dental anxiety is super common. Children, youth, adults, and it's especially common in folks who have developmental differences. We can think about behavioral strategies as ways that we can manage things in the clinic in a different kind of way and help to navigate that appointment to get past the anxiety and build long-term success. So this is not someone who's only coming in for one appointment and never going to the dentist again, hopefully. So we're really building on a good opportunity, small steps, and then having improvements over time. And then if you feel like we cannot do the amount of exposure that's required, then think about referral to a behavioral specialist or a pediatric psychologist, and then we're happy to work on it in a more intensive kind of way.
So, our last speaker of the evening is Dr. Stuart Wright. Stuart is a longtime friend and pediatric anesthesiologist, and he is an acute and chronic pain specialist at the IWK Health. Stuart has a PhD in endocrine psychology and a postdoc fellowship in molecular medicine. Stuart's career took a new direction when he pursued medical school at Dalhousie University. He then trained, including a residency in anesthesia, followed by fellowships in ICU and pediatric anesthesia, with a focus on acute and chronic pain management. He is the undergraduate coordinator for communication skills in Dalhousie's Faculty of Medicine, developing and delivering curriculum on patient-doctor communication. A personal experience as a parent of a child with autism has deeply influenced Stuart's commitment to improving healthcare for children with autism and their families. This journey inspired him to help develop the Balance Program, an initiative aimed at enhancing care for these children. Stuart remains passionate about sharing this program and advocating for better experiences for children with autism.
Excellent. Yeah, so the Balance Program. So what does Balance stand for? It stands for Building Alliances for Autism Needs in Clinical Encounters. Amazing how that all lined up, right? It was all natural. The thing to know, so I'm going to talk a little bit about it, but I'm really going to just focus on the principles of it, things that you can use and take home. It is an online educational program that is available, and the guy who's taken it over, I think, is actually in talks with Dental Association to try to broaden its exposure. All right, so basically when everything else fails and you can't, you've got too much to do, they don't tolerate whatever you're trying to do, and they won't listen to Joanne, that's when you call me. And that's when often they're going to need a general anesthetic. And so that's a GA, a general anesthetic, meaning so that they can get all of the work done in a more concentrated and worry less about the patient, because the dentist will be the surgeon, the one who's doing the procedure. The anesthesiologist, their job is just the patient and patient family as well. So the process, so what is a general anesthetic? So you first have to come in, you have to be prepared, you have to be fasted. Then there's going to be a pre-anesthetic assessment that might happen days before. Then you're going to have to get what's called an induction. And that is how are we going to get you asleep so that we can then intubate you and then take care of you. So inhalation means breathing gas. IV means pop the IV in and then get a bunch of drugs, happy drugs and stuff. Then we're going to actually secure your airway with an endotracheal tube or a laryngeal mask or nasal prongs. So we might just be providing sedation so that somebody breathes on their own and actually gets their dental work done. And I just had my first experience of doing this for somebody in a dentist's office. And we did 2 hours, 2.5 hours for the first patient and 4 hours for the second patient. So it can be done. It's the neat thing. And then when you have a general anesthetic, you actually have to wake up from it and you have to be able to recover and then go home. So when we looked at that whole process, we figured that what do we need to do in order to make it better? We need to look at some factors. So we need to look at child factors, family factors, healthcare provider factors. When we're talking about the child, we need an individual plan, an individualized plan. When we talk about the family, we need to get like who is an expert on the child? The family. And then as healthcare providers, we have expertise. And we need to figure out how do we marry those two things. So the way we've done it is we've provided a framework, a sort of blueprint in order how to get that done. So specifically with autism, but to be honest, this works for anybody who's got behavioral difficulties. And I've actually changed it to behavioral challenges. Sounds much better, right? So part of what that was figuring out that we need to take a step back. But in this case, SEC actually stands for something. So it stands for sensory, emotional, and communication needs. And so what we did was we we came up with a tool for that. When you look at the family, we need to focus on the family. Families are already stressed. They're overwhelmed. And on the day of the healthcare experience, they're worried about their kid. They're worried about how everybody's going to respond to them, how they're going to think that they've failed as a parent, as a person. There's a lot of anxiety. What can we do? We can work by collaborating with them and partnering with the families. But also you need to sometimes be explicit. I'm on your side. It's us together. We're part of Team Charlie, and that's to get your kid, Charlie, through a dental experience. It's the dentist who's the problem. It's, oh, wait, no, wait. So acknowledging the stress and conveying empathy can go a long way to creating a good experience. But also, so focus on yourselves. So your critical role is providing individual care, promoting the unique needs of each child. So knowing that kid and saying, yeah, you know what? This kid is actually hyposensory, so he's going to want pressure. But you're going to get another kid, could even be their sibling, who's hypersensory. They want nothing touching them, right? So you're going to figure out a way to hover things. You're going to figure out, and then, you know, addressing their unique needs and then offering empathy to the families, because that's all they, a lot of times, that's just what they need to know, that it's okay for them to be there, that, you know, that you're happy for them to be there. Now, for yourselves, it's okay to know that having difficult thoughts and feelings in a challenging situation is normal. It's okay to feel bad about it. It's okay. It's that using the balanced program gives you a way to focus and not just sit with those feelings, but to take action on top of that. You know, these bad feelings, acknowledging them, but they only become a problem if we don't do anything with it, if we let them get in the way. So that's the overarching part of it, but let's put it into practice. Let's do a case. This is the fun part. So we have an 8-year-old female with autism and ADHD. In the past 3 months, she's had a lot of worsening behaviors. She's been doing self-harming, lunging at other children, biting, lashing out, hitting, and she's been really acting out in her sensory room at the school. So the pediatrician is wondering, could this be dental? Could this be ENT? Could it be a medication side effect? Nobody can get near this kid to try to do any blood work. So you now know this history. You know the struggle. So where would you start? What would you do? Who would you involve? So what do you guys think? Go on, say it. You involve the family, exactly. And you create a team. And who's the top of that team? It's actually you guys, not the pediatrician. They're the problem. No. Actually, in our world at the IWK, it's actually the dentists that run most of this stuff. Pediatrician says, yeah, I'm having trouble. Tracy, can you figure this out? And so the dentist is actually pretty much top of the heap. Dentists actually, they own the most OR time at the IWK, more than the general surgeons, more than the urologists, the orthopedic people. Dentists rule. So you're going to put the team together. You're going to get the dentist. The dentist was actually probably going to consult the ENT surgeon, the anesthesiologist. So the dentist books some extra time and then make sure that ENT is available. They make sure that the lab is available. And then we can start with, how are we going to manage this kid? So are we going to add some pre-meds and then pre and post-op care? So that comes to the anesthesiologist. And then he says, who do I need to call? I need to call mom. And so call mom. She's the most important person because she's the Charlie or Chrissy expert. it's so important to also recognize that and give them credit for knowing their kid. So we just say, do you want a phone consult? What are your concerns? How can we best help your daughter? And so what we have is an organized approach. So we figure out our sensory, emotional, and communication issues. We use the tool to provide benefit to all the other healthcare providers. This is the way to interact with Chrissy. So what do? We take a sec. So the sensory part, we ask, what sets her off? Noises and touch. And how do we make that better? Well, then we provide headphones to decrease noise. We minimize touch as much as possible. What are some of the emotional things that your child experiences? Uncertainty, procedural fear. How are we going to manage that? So when in this tool, we actually have solutions and we say, which ones do you want to pick? Show, tell, do. And minimize the wait time. And then minimize interaction. So what else? So what communication? How does your kid let us know what's going on? Facial expressions. And then what do we need to make that recognized? Use the family as an interpreter. So now knowing all of this, let's put a plan together. So the first thing we do is we minimize the wait time. We get them to bring an iPad, or we provide an iPad and headphones so that they can use distraction. Allow them to stay in their clothes. Getting them to change and put on somebody else's clothes and feel half naked. Believe it or not, kids don't like that. So they'll put up with it, but some kids can't put up with it. We're going to minimize interactions. We're going to say, what does your kid weigh? We don't need to get their clothes off and get them to stand on a scale that's in the hallway so that everybody can see. If you have a kid who really doesn't like to hear stuff, then pull mom out of the room. But then you'll have another kid who wants to know everything. So do the conversation in the room. And then pre-op sedation. So in this case, Chrissy actually likes pickle juice. And this is a real case. This actually happened. And so I said, Mom, bring the pickle juice. And we're going to give some sedation as soon as you arrive. And then with hospital anxiety, we can try to have child life specialists, but also with that kid to reassure them ahead of time that mom can come in the room with them. Mom is not going to be abandoning them. Now, my question, what do you think about when somebody says, oh, you're so brave. Oh, Chrissy, you're so brave. What do you think of that?
I think if it happens once, it's not a biggie. If that's the only thing the person has in their kind of like toolkit, then that's the problem.
Yeah, it makes me cringe because the first thing that just reassures them that, yep, this is the worst thing that could happen. And so they start saying, well, what could that mean? They're going to slice me open and chop me into bits. And yeah, then it's going to take out all my teeth and my tongue and my lips. And I'm just going to be going, arr, arr, arr. So instead, we try to use distraction, or we use a pre-medication. So a pre-med, really we shouldn't call it pre-op. It's a pre-op medication. It's not a pre-med because that would be a medication before a medication. I don't know. Anyway, so one of the things you'll see used a lot is midazolam. So midazolam is a benzodiazepine. The difference, midazolam is very fast acting, so it's fast on, fast off. Ativan is really long acting, and its half-life is between 6 and 18 hours. So it works, but it doesn't give you that, in some cases, you're looking for an altered state. This paper, even though this is ophthalmologic surgery, it works for everything. This is something we've adopted. So we use midazolam, 0.5 milligram per kilo. If you were giving it IV, you'd give 1 to 2 milligrams. You're giving it by mouth, you're giving 10 to 20 milligrams. It's quite a difference. The thing that we will often do is add ketamine to it. And ketamine is a really nice dissociative medication. It kind of You tend to have a good experience. You feel good, but you kind of dissociate, kind of float away from your body kind of thing. That allows the midazolam to work a lot better. The kids with the most behavioral difficulties, that's what we use. Quite often, if you have somebody who gets a pre-medication, have you ever heard of a paradoxical reaction? Yeah. So the paradoxical reaction is probably just a fight or flight because they're feeling altered. They're in a scary place. They're like, if I go to sleep, they're going to chop me up, take out my lips. And yeah. So instead, that's what, to me, happens with a paradoxical. They just don't know what to do with this new feeling. And adrenaline will blow through any sedation. So that's a truth. But adding the ketamine, they start to actually feel good. And then they dissociate a little, and then they're allowed to feel relaxed from the midazolam. That's the way I like to use it. And using it in the dental office is, it's okay because those together don't cause respiratory issues, which is what you worry about with some others. So what I wanted you to know is that this table basically just says using a low dose of 2 good drugs is better than using a high dose of 2 good drugs. And the amount of time it takes to recover, 22 minutes versus 52 minutes. So you can be efficient with this, but what does it look like? So here's rather than showing an actual kid, this is what midazolam does. Yeah, it's nice when it works. Now, when you add ketamine to it, it might not knock them out, but they're nice and stunned, right? They're just like, wow, I still feel really good. They're very suggestible. They will follow commands really well. They'll be like, oh, let's go to the OR. Okay, let's go. And then you're like, here's your mask. Okay, here's my mask. And then you turn what was a very scary and negative experience, you can turn it around, that it becomes a very positive experience. Then the next time they're like, you know what, I don't want to feel sleepy like I did the last time. Let me see if I can do it without. Let me just see if I can go with the mask alone. And we have seen that kind of turnaround, especially for kids that have to come more than once. But if they have to come once, these are very helpful things. Right, what do you do if you get the kid who does not want to take anything by mouth? That's when we go into intranasal. Ideally, it's low volume, so we try to use more concentrated solutions. One of the problems is that midazolam up the nose burns. It's nasty, but it's only nasty for about 30 seconds. And then they start to feel more relaxed. So it is, again, something that you can do, but it's kind of like you can do it once, maybe twice, but they are not, once they see you coming at them, it's better to talk them into the oral solution. Even if you taste something bad, you'd be like, it tastes bad, but they might forget about it. So, and basically anything you can go up the nose. So you can have midazolam, ketamine, and if you're having pain issues, fentanyl. So these are all the things you can do without an IV. So what were the concerns? Concerns for Chrissy, she was a flight risk. She might have some outbursts, some bad behavior. She might have anxiety, and you're worried about safety. And what we did was we addressed all of those things. So the pre-op went according to plan. Sedation was given. She took it by mouth. She had a little popsicle she could have afterwards. Popsicles, by the way, numb your tongue. And the cold numbs your tongue. You don't taste as bad. So I actually get them to eat a popsicle first or suck on an ice cube. Numb up the tongue, then take the bad tasting medicine, then have a popsicle chaser. Mom came to the OR and Chrissy played with her iPad the whole time, just put the mask in. She's like, fine, whatever. And then 30 seconds later, she was asleep. Dentistry checked her out. They let ENT have a look in her ears. And then she had a nice long sleep and recovery. And that was it. It was a very nice experience. So the program that we developed it was actually dentistry, psychology, and anesthesia developed this program. And it's 7 online modules, and we have the toolkits. And the toolkits are communication between healthcare teams. And it's something that's easy to adopt for the office. And that's that.
Just for the dentists in the room too, there's good evidence that says that children with autism who have behaviors out of the norm, not explained by any other factors in their life, they blame it on dentistry first, but they have a dental issue. ENT second, so they could have earaches, sinus pain, and third is like gynecological or genital urinary, so like urinary tract infections, whether male or female. So those are the 3 different services that are most responsible for abrupt acute changes in behaviors for this population. So what the situation that Dr. Wright was explaining is so common. The child gets admitted to the IWK with atypical behaviors for them. They try, test everything else, look at everything else. And our last resort is calling dentistry to arrange an anesthetic. So we can check teeth and they can do blood work and ENT can look in the ears. It's super common. And part of the reason I asked Stuart to be here today is that all of you who are going to become practitioners who care for this population may also seek out sources of deep sedation or general anesthesia. You may become practitioners who work in a local hospital or have someone like Stuart come into your office to provide anesthesia. And we see a lot of kids, particularly from rural parts of New Brunswick or rural parts of Nova Scotia, that their perioperative management before going off to sleep, the people that are caring for them don't have a lot of experience. And so they're declined or rejected from those programs and end up at the IWK. Simply not because they have, advanced dental care issues that can't be treated by any general practitioner, just because the team didn't know how to manage them in the perioperative area. So, you may not be the one giving the ketamine and midazolam, but you may be faced with situations, when you get out there, that you may be able to help your team to care for somebody with a pre-med, with a balanced program, with distraction, because it certainly happens to us that, we end up getting unnecessary referrals for kids who could be treated locally, but, the team can't manage their behavior for safety reasons and so on.
To give you an example with midazolam, the idea, you're going to be a gatekeeper. So give the kid the midazolam, and then the parent, you sit there and just start picking it. And they're like showing them a video, and they're like letting them play on their phone and play a game. That's engaging. It's the idea behind sedation is to remove the stimuli, to make a non-stimulating environment, to allow them to react, to allow them to go down. Oh yeah, allow them to go down. It really makes a difference if you see a parent. I had this one parent, and the kid's like nodding off, right? It was the kid, and mom was like, Charlie, are you going to sleep? And you're like, and I pulled mom out, and I'm like, what are you doing? I said, we're trying to get them to say, oh, but I'm just worried. I said, well, ask me about your worry. Let the medication work on Charlie. And we can turn it into a humorous encounter so that it doesn't make them feel bad. It's like, I understand, it's very different to see them like this, but this is why you're here. This is what we're trying to do. This is what we're looking for. Also, it made me realize I didn't prepare her as well, because I didn't know what her deficit was. Like, I didn't know that she didn't realize that sedation means going to sleep. So, and you can come along and kind of get the parent, tell you what, why don't you start playing on your phone and just leave your kid alone? And then let's not try to activate the kid. Let's just let them have an experience. Let them be bored, because if they're bored, they'll probably close their eyes. Yeah.
Great.
Success with midazolam and ketamine in combo for adults with disabilities in their private practice.
Sweet. Okay, so that person, a dentist, that is very brave. That is very advanced, and I think that's fantastic. It's somebody who's looked at the literature and realized that I can put it into practice. So many people will read this stuff, they'll hear about it, but they'll never take that step that'll get them there.
And that could be related to provincial regulations around sedation though too. So for instance,
Fair enough.
in order to use more than one drug, you have to do advanced training such as a residency, like Dr. True and Dr. Tevin were doing. So in the province, to use even nitrous oxide combined with an oral drug, you actually have to have advanced training to do so. As a graduating dentist, you can take a course to do nitrous. It's only just a weekend, and you can give an oral drug on its own, like Ativan or midazolam. But together, you need advanced training, and usually you need advanced airway courses like ACLS or PALS as well. So yeah, you do have to refer to your local provincial dental board as to what their sedation guidelines are.
Yeah.
Do we have any questions from the students? Amazing. So if we want to make sure that we're using our mics just so that everybody hears, wonderful. Thanks. Okay.
The question is, do you have any advice for community practitioners who get pushback from MDs regarding safety of GA?
Sure, that's for you, Joanne.
Mm-hmm.
No, I'm just kidding. There's always going to be somebody. You can find fault in anything. The thing to know is that the sedation, the midaz plus nitrous, midaz ketamine plus nitrous, is very safe. And the MDs who would be giving pushback, I would be wondering why. What are they looking for? What are they worried about? Because those things are very safe. If you're giving fentanyl plus those things, yeah, there is a chance you're going to stop them breathing. If there is a chance to overdo it. But in general, if you stick with the known guidelines, if you have a chat with anybody who does sedation, they'll be able to say, you can very safely give an anesthetic, or not an anesthetic, a sedation. It just takes a little practice.
And I think what he's referring to is getting pushback, MDs getting pushback, giving pushback to dentists about doing general anesthetic for dentistry.
Yeah, I mean, doing general anesthetic on your own, that I would say I wouldn't, because it's too much. You want to have an anesthesiologist there. To do it, yeah, I think the main thing is you need to separate it. Being a good dentist means focusing on the work at hand. Being a good healthcare provider means being able to focus on the kid themselves. And the other thing is to make sure that you have monitoring. So the other day when I was doing it, actually yesterday, we had oxygen levels, we had carbon dioxide levels, we had a resp rate counter, we had EKG leads, we had blood pressure, we had oxygen saturation. Make sure that you have, and we had me dedicated to watching that while the dentist was dedicated to providing the best oral care. Because he didn't have to think about anything, he could do things in a much more efficient and timely manner. And occasionally we actually had to lift that kid's chin up because they were starting to, their tongue was starting to fall back. They were starting to snore a little bit. And so we just said, hey, can you turn her head a little bit towards you? And he was like, great, did that. Airways unblocked. So I would say doing this, it's really important that you have somebody dedicated to watching the monitors. Yeah.
There's lots of thank yous and everything and great works in the chat. Nice. One person says, what is your opinion regarding the lack of willingness to get providers to even see a patient with IDD?
Suck it up, Buttercup. Write it down. That was the movie, right? The movie was saying, yeah, I'm stuck with mine on.
That doesn't work, Tracy. Yeah.
Can you hold it down?
Yeah, you have to remember, Shauna, you have to go with that.
To hold it.
Now you have two on them.
In my personal philosophy is start in dental school. So part of the reason that I continue my involvement with Special Olympics, I love it, and it's almost like an addiction. You know, once you start, you'll never stop, and I just keep getting more and more involved. But part of me also, as long as I am faculty at Dalhousie, I do it also to remain an educational component within the program, because study after study shows that the didactic content can be delivered, and schools have more or less didactic content depending on where you're at, but the clinical hands-on component is very difficult. Our clinics don't lend themselves to being attractive to this population. They're open bay concepts, they're noisy. You're with a learner who's also learning the basic skills involved. It's very hard for them also to manage challenging behavior. I remember my poor patient in dental school with advanced Parkinson's and tremors, and trying to work on a patient such as that when I was still trying to learn the basic skills is very difficult. That's probably my only experience in dental school. So this is, even though you're not doing clinical dentistry when we're screening athletes, it still gives my students an opportunity to interact with the population, to provide an examination, provide oral health education, to learn the communication skills. So we did a little follow-up study with our volunteers that are now in clinical practice, and overwhelmingly we found that it made anybody who volunteers with the program for Special Smiles has more of a willingness then to proceed and see this population. So my answer is start in the dental schools and make sure you have a contingency of students who are then going to become your go-tos for referrals later on. The other thing we're doing at CSDH is a fellowship. As the board knows, that we're developing a fellowship program where practitioners can self-identify and provide evidence and receive a fellowship designation so that they can be champions in the profession and referral sources and education sources. So we're trying both to recognize because it's not a specialty. There's no dental specialty specific to special needs dentistry, whether it's intellectual or developmental disabilities or senior care. It tends to fall under the realm of pediatric dentistry. So we're trying to recognize health professionals outside of the pediatric dental specialty for what they do, and also, again, foster right from the beginning with students.
I heard shape that behavior, and then it's reinforced because it's a meaningful kind of experience.
It's a great answer.
This is a question for Joanne. Have you ever tried EMDR for those kids who are anxious from previous traumatic experiences?
I am not trained in EMDR, but my understanding of it is the active component is still exposure. And so you're getting someone to do something in terms of moving their eyes a certain way as they're doing a trauma narrative or talking about something that's been stressful or tapping certain areas. But to me, the active component in that is the exposure piece of it that we've been talking about. And so the idea that you're going through and discussing things that have been challenging and being exposed and managing that is what's actually active. That's the active ingredient. So the tapping may add something on top of it, but not something that I've been trained in, no.
What does EMDR stand for?
Eye movement desensitization and reprocessing. Olaf just has his hand up here. I don't know.
Olaf, you
Can I
go right ahead. Yes, you can.
Okay, thanks very much.
So, sorry to
but-
introduce you. This is Olaf Klatsky, founding member of the CSTH. Huge
Thank you.
advocate and proponent for people living with IDD. You go for it.
How much time do I have? Okay, so very briefly, Clive's also on this call. He's just a little more shy than I am. So thank you all for this incredible presentation. And I also have to speak to Tracy regarding education. I have to admit, and a certain dental director at a certain school agrees that with the help of all of you, that in the last 6 years that CSDH has existed, the awareness of people with disability has absolutely skyrocketed more than it ever has in oral health care provision, I guess is the best word I want to use. The student chapters, which you folks are leading with, have been an incredible resource, and it's growing. I'm not sure if Drew Smith is on this call. He's in charge of the student resource or student chapter program, and he's managed, I think, to get programs started at least at close to 7 schools. We have faculty champions. Change is happening. It's not happening as fast as some of us would like, but it is happening. And with the funding that's occurring both, I think at Dal, I'm not sure if Dal is the one that got the one for the ACFD, which is going to be starting looking at curriculums in the slightly more inclusive fashion, including marginalized populations, seniors, and people with disabilities. So that's underway, and Lindsay's in charge of that from the disability standpoint, so I congratulate her. But things are happening. Western has received $3 million to get students out in the community more to learn about working with people that, dare I say, if I can, living on the edge, that don't have the means, the resources, or even the access. So things are happening, and I congratulate everybody on this call and everybody who continues to be involved with CSDH for getting a movement started. And I hope everybody that's listening in the room becomes part of the program and part of the change. So thanks very much for your time.
Thanks, Olaf. So just so everybody's aware, what he's referring to is the program that was released by Health Canada, the federal government, alongside of the CDCP, so the Canadian Dental Care Plan. It's referred to as the Oral Health Access Fund, and it is designed to address non-financial barriers to care. So how do we train providers to be able to be competent and willing providers so that those that now have dental insurance actually have a dental home to go to. And so each of the 10 dental schools across Canada were eligible to apply, as well as some of the dental hygiene programs and dental assisting programs and therapy programs across Canada. And the ACFD, which is the basically organization that houses the 10 dental schools, have their own fund. Theirs is addressing special needs curriculum as well as DALs, and I'm sure that there are others. So, the education that those coming after you will receive will hopefully be more fulsome in this area. That's our goal. Well, this feels like a good place to end, being respectful of everyone's time. And so I'm going to invite Annika to come on up and just say some closing remarks.
Right. Well, thank you everyone for coming tonight. I'll just try to keep this short just in the sake of time. But I first wanted to say thank you so much to all of our panel members. This was super informative, and I think I can speak for everyone that feeling very inspired and just have so much more knowledge now. So it's so amazing. I also want to say thank you to the CSDH in general and Shauna as well for kind of spearheading this panel discussion here today, and just the Beyond Barriers kind of series going on right now is incredible and giving us so much more knowledge and information to all be better practitioners. Also amazing to have dentistry, psychology, and anesthesia all coming together, and I love that so much. Yeah. So anyways, thank you all so much and have a good night. Oh, and we have some gifts here as well. Where? We should have had tea recycling. Thank you.
We'll say goodbye to our friends online. Thanks for joining.